everyone. It is a great pleasure to present my thesis work here. I'm Angela Yao. My talk will be on evaluating a wildfire smoke forecast tool, which will be beneficial for mitigating health impacts from wildfires. First, we will have an overview of my presentation. I will give an introduction of some background information about wildfire smoke and its health impacts. And then I will describe the two research questions in my thesis. And second, we will talk about the methods and the results. And finally, we will have the conclusions and suggestions for some work that can be done in the future. We know Canada is a very forested country. About 40% of Canada is covered by forests. But at the same time, it is also a country massively impacted by wildfires. On average, about 8,000 fires have occurred each year past decade, and about 2.1 million hectares of forests have been burned annually. Weather is a very important factor determining the occurrence and the spread of wildfires. Some studies have suggested that climate change can lead to more frequent fire occurrence, more intense fire activity, and much longer fire seasons. For example, in Figure A, the red bars indicate the wildfire frequencies in each year, and the black line indicates the average spring and summer temperature. We see that there's some kind of correlation between the two. Since mid-1980s, both the temperature and the wildfire frequencies have and in Figure B, the colored area represents the length of fire seasons. Also, generally, we can see that since mid-1980s, fire seasons have been much longer than the while wildfires can be a direct threat to life and properties, it is the smoke that it emits that can impact very large areas and for very large populations. It can have local, regional, and global impact. I recall there are several very hazy days in this year in Brazil, and that was the result from the smoke from across the Pacific Ocean, massive burning in Russia. Wildfire smoke is a very complex mixture of different gases and particulate matter. Among all these components, it is the fine particulate matter of our most concern. It is commonly measured as PM 2.5 particulate matter with the diameter smaller than 2.5 microns. There are three reasons for our special interest in these pollutants. First, it is as the most constantly and greatly enhanced pollutant by wildfire smoke, even at places pretty far away from the fire locations. And secondly, it can impact very large populations by its long-range transportations. Because of its small size, these particulate matters can remain suspended in the air for a very long time, so that it can be transported from long distances. And thirdly, it has been associated with different health responses, both by toxicology and epidemiology. Among the epidemiology studies, there has been pretty sufficient evidence on the association between wildfire smoke exposure and respiratory health responses. For example, in this figure, the blue bars represent the asthma physician visits increased and the PM10 concentrations during the Kelowna forest fire in 2003. We can clearly see the correlation between the two. In terms of cardiovascular diseases, there has been limited but emerging evidence on its association with wildfire smoke exposure. A very recently reported study has found association between maternal exposure to wildfire smoke and low birth weight. To better assess and mitigate these health impacts from wildfire smoke, we need effective tools to measure this exposure. One of the commonly used tools is the monitoring network. In British Columbia, there are about 55 monitoring stations with hourly PM2.5 measurements across the province. The good things about monitoring network is that it can provide ground level measurements, which is the population actually exposed, and the measurements is relatively stable and accurate because they measure the particular matter directly with sophisticated instrument. However, one of the downsides of monitoring network is that it is usually spatially sparse. Even in British Columbia, where it has one of the most densely distributed monitoring network in North America, we can see in this map the green dots represents the monitoring stations and the red dots represents populations. Even in BC, there are still regions with populations but without any monitoring stations. And another downside is that the instruments used in monitoring stations can fail confronted with extreme high values, which is very commonly seen during wildfire events. Another useful tool is the remote sensing. As you can tell from its name, it measures things from great distances without physical contact with the object. After the radiation emitted by the sun reaches the ground, it will be bounced back, and this bounce back radiation can be reported by sensors on satellites. When these reflected radiations go through the atmosphere, it will be influenced by the particulate matters and the gases in the atmosphere. So by analyzing the radiations bounce back to the satellite sensors, we can then detect smoke in the atmosphere. One of the remote sensing tools developed specifically for wildfire smoke is the hazard mapping system. It provides images of hand-drawn smoke plumes by trained analysts after they observed images from 7 different satellites. It can cover very large areas, basically the whole North America. And by integrating information from different satellites, it can overcome the limitation of each individual satellite. However, the images can severely influenced by cloud, and there's no detection at night because it used the visible band of the sensor. Also, it can only detect smoke in the total column of the atmosphere instead of only the ground level concentrations of our interest. Both the monitoring network and the remote sensing tools we just talked about can only provide retrospective or near real-time information about wildfire smoke. But for many other public health hazards, such as pollen and UV exposures, there's already forecasting system in place to provide information in advance. So why we need these forecasts? Simply, we need time for public health actions. We want to inform the public and get prepared before these hazardous events actually happen. Specifically for wildfire smoke, it is a very short-term exposure in North America, but it can reach a very high level in this very short period of time. So a timely forecast and a timely public health action can be very vital to mitigate the impacts from this wildfire smoke. Aware of this need, the development of the BlueSky Western Canada wildfire smoke forecasting system was started in 2008, and the output of this forecasting system has been publicly available on this website since 2010. The output includes hourly PM2.5 predictions up to 60 hours in advance. The spatial resolution is the latitude-longitude grid with 0.1 degree spacing. The major structure of this system includes two parts of inputs. First is the hourly meteorological forecast. It provides information such as wind speed, wind direction, and temperature. The second part of the input is the wildfire information, such as the locations of the fire, the fuel consumption, and the primary emissions from these wildfires. With these two parts of information, we can input them to the high-split dispersion model, and then calculate the ground level concentrations of PM2.5 within the domain of this system, resulting from the dispersion of the wildfire smoke. So the output of this system provides ground level information, and it can provide information in advance because it is a forecasting system. So the only question we have is that how does this model actually perform? Can it really predict what's going to happen in the future? So that's the first research question for my thesis. How does the prediction model BlueSky compare to the monitor measurements and the HMS estimates? By comparing the output of the model with these two retrospective or near real-time measurements, we can have an idea of the performance. We also have a second research question. Is there association between BlueSky predictions and health outcomes? The rationale behind this second research question is that if we can find association between BlueSky predictions and health outcomes, it can well support the idea to use BlueSky predictions to inform public health decision making. For example, with a specific level of BlueSky predictions, we should issue health advisories to advise actions such as staying in rooms with air conditioning or air cleaners, to prepare enough medication for people with pre-existing diseases. In this study, we focused on the province of British Columbia, and the study period is from July 24th to August 29th, 2010. 2010 was one of the worst wildfire seasons in history in British Columbia. and the map on the right presents the locations of all wildfires. And we can see that most of the large fires were in the central interior region. Places like Prince George, Williams Lake, and Cornell were heavily impacted by this wildfire smoke. For the first research questions, we need 3 types of data. The first one is the daily averages of the hourly BlueSky PM 2.5 predictions for 2010 fire episodes. As we've mentioned before, each BlueSky forecast contains predictions for 60 hours in advance. So from each of these forecasts, we can extract 2 24-hour averages. So we will have a BlueSky 24-hour predictions for the next day and a 48-hour predictions for the day after tomorrow. The second type of data is the daily smoke plume images from hazard mapping system. And we also have the daily averages of the PM 2.5 monitoring measurements at 33 locations in BC. The last 2 data sources will act as our reference for the evaluation of the BlueSky predictions. First step, we will compare the locations, sizes, and shapes of the plumes predicted by BlueSky and observed by HMS. To quantitatively assess this spatial agreement between these 2 plumes, we use a statistics called figure of merit in space, FMS. It is a pretty simple statistic. It can be calculated by dividing the intersection between the 2 plumes and the union of the 2 plumes. The range of the statistic is from 0 to 1, and a perfect spatial agreement will have a value of 1. This figure presents the daily plume areas of HMS in blue and from BlueSky predictions in pink and green. We can see that all of these exposure measurements and predictions peak during the same period of time. It indicates that both HMS and BlueSky can capture the major wildfire events during our study period. And we can see HMS plumes, which is in blue plots, were larger than BlueSky plumes most of the time, especially in the middle of the fire episodes. This figure presents the daily FMS scores calculated between BlueSky and HMS. The major fire periods were highlighted in orange in the background. We can see that FMS scores are much better during the middle of the fire periods. And the mean FMS scores during our study period is around 0.2. This result compares well with the results from another study on the small forecasting system in the US. The second step, we will compare the PM 2.5 concentrations measured and predicted at 33 locations during the study period. A total of 4 models evaluation statistics were calculated in 3 types of analysis: global, spatial, and temporal analysis. In this presentation, we will only present the results of 2 models, 2 statistics. The first one is the fractional bias, which can be calculated by dividing the difference between the predictions and observations by the average of them. The range of FB is from -2 to 2, and a perfect agreement will have an FB of 0. Another statistics is more familiar to us, which is the Pearson's correlation coefficient. It has a range of -1 to 1, and the perfect correlation will have an R value of 1. In the global analysis, all predicted and observed values at any time and location were included in the calculation. In these two blind almond plots, we plot the difference between BlueSky and Monitor against the average of them. The dots above 0 represents over predictions from BlueSky, and the dots below 0 represents under predictions by BlueSky. We can obviously see that the major discrepancies were driven by the extreme over predictions by BlueSky. This trend can also be observed by the FB values. Both of them were above 0, indicating over predictions, indicating more frequent over predictions or over predictions of a much larger scale. In the spatial analysis, BlueSky predicted and monitoring station observed values of all locations at a fixed time were compared. So in this analysis, we want to know on a specific day if places with high concentrations actually got high predictions. For example, on August 17th, we can calculate the R values and the fractional bias from the measurements and predictions at these 33 locations. We have a result of R of 0.68 and a FB of -0.01, pretty close to 0. So on this specific day, we have a pretty good agreement between monitor measurements and BlueSky predictions. And using the same methods, we can calculate the daily statistics for during our study periods. In this figure, it presents the fractional bias for each day during our study period. The bars above 0 represents over predictions by BlueSky, and the bars below 0 indicates under predictions. Again, the orange background highlights the major wildfire periods in our study time frame. We can see that generally during the wildfire events, the absolute value of the fractional bias is much smaller, indicating that agreement was generally enhanced during the middle of fire periods. But we can see more frequent over predictions during this wildfire, during the middle of the fire period. In temporal analysis, a whole time series of BlueSky predicted and monitoring station observed values for a fixed location were compared. So in this analysis, we want to know if at a specific location, if days with high concentrations actually got high predictions on that day. As you can see from the map in the left, it represents the correlation coefficients calculated from the time series at different locations. We can see high R values in places like Vanderhoof, Prince George Canal, and Williams Lake. When we compare these results with the map of major fire locations, we can see that good agreements were observed in areas most impacted by fires. In this case, it is the central interior regions in 2010. Second part of the research is to assess the association between blue sky predictions and health outcomes. The whole province of British Columbia is divided into 89 local health areas. Most of the administrative health data were collected based on this unit. In our analysis, we also use this unit as our basic unit for the analysis, and we use count data aggregated based on this unit. We use two types of health data. The first is the medication dispensations. It is the daily counts of salbutamol sulfate prescription dispensations in each of the LHAs. Salbutamol sulfate is a commonly used medication for the relief of symptoms caused by asthma and other chronic airway diseases. And we also have the daily counts of MSP claims for physician visits for asthma. With these count data, we can calculate the outcome rates by dividing the daily counts in a specific LHA by the population in this corresponding LHA. This table presents a summary of the health outcomes. Overall, there were about 34 cases per 100,000 persons on each day during our study period of medication dispensations, and the number for physician visits is 9.3. We can see that on weekdays there are much more cases than weekend and holidays. This is reasonable since most clinics and pharmacies were closed during weekend and holidays. In addition, we can see that there are quite a large range of outcome rates among different LHAs. This indicates that there might be some geographical factors influencing these health outcome rates. In our analysis, we used a total of 6 exposure variables. The first 3 variables are binary variables. For LHAs, if there are any population in the LHA covered by smoke plumes, either predicted by BlueSky 24 hours in advance or 48 hours in advance, or observed by HMS, it will be assigned a value of 1. If there's no population covered by these smoke plumes, it will be assigned a value of 0. And there are 3 continuous variables. They are the PM2.5 concentrations predicted by BlueSky or measured by monitors. With these 6 exposure variables and the 2 health outcome measurements, we can build a total of 12 Poisson regression models. In these models, we also account for 4 other covariates. The first one is the daily maximum temperature. Since it is a potential confounder for our analysis. Exposure to high temperature has been associated with the respiratory health outcomes, and it also highly correlated with wildfire events. And The other two covariates we account for is the day of week and holiday. Since we've mentioned before, there will be a sharp decrease of health outcomes during holidays and weekends. And the final one is the number of week, which we use to account for any unexplained time trend of the health outcomes. As we used all health outcome rates from different LHAs on different days, so health outcomes from the same LHA may have some inner correlation. To account for this correlation, we use the generalized estimation equation to estimate the parameters in the regression model. This figure presents the relative risk associated with being covered by smoke plumes. So it presents the results from the three binary exposure variables. As we can see, most of the lower bound of the confidence intervals were above 1, indicating significant increased risk of health outcomes by exposure to smoke plumes. And also, we can see that the relative risk are resulting from the blue sky predictions are very similar to the ones associated with HMS plumes. This figure presents the relative risk associated with 30 microgram per cubic meter increase in PM2.5 concentrations. So it presents the results from the three continuous exposure variables. And we can see most of these relative risk most of these associations were significant. And for the medication dispensations, we can see that blue sky predictions were associated with a much smaller relative risk comparing to monitors. One possible explanation for this is that the prediction errors resulted from blue sky may drive the association towards now. So the conclusions for our talk. Blue sky predictions could successfully capture smoke plumes with high concentrations, and it tended to overpredict high concentrations. Good agreement tended to occur during the middle of the fire period and in severely impacted areas. I think these results from the model evaluations are very encouraging, since it is our most urgent need to have good predictions for severe smoke in heavily impacted areas. And finally, the final conclusion also we have is that the blue sky predictions are significantly associated with health outcome indicators. This can support the idea of using blue sky predictions for public health decision makings. So some work that can be done building on the results from our research. First, the blue sky forecasting system is an ongoing project, and improvements and enhancements has been constantly implemented. So follow-up evaluation of this evolving system is crucial for its development. And second, an in-depth investigation on the specific parts of the system will be crucial to find the cause of the poor performance on some days and in some areas. And finally, Our ultimate goal is to use these smoke assessment tools to inform public health actions. Ideally, we would want to develop a tool to give quantitative guidance on specific public health actions corresponding to specific smoke levels. But this cannot be achieved without further research on how to combine all the available knowledge on smoke health impacts and how to effectively use all the information from smoke assessment tools. To end this presentation, I want to thank my supervisor, Dr. Michael Brower, my committee members, Dr. Sarah Henderson and Dr. Ian McKendry, and Mr. George Hicks for providing all the blue sky prediction data, Steve Sakayama from BC Ministry of the Environment for his useful comments and feedbacks for my research, the Environmental Health Services Group at BC CDC for providing the access to those health data, and my funding from Create AAP and BC Clear. Thank you very much.